Hello, I'm Dr. John Kruse, and welcome to this week's question and answer hour. I hope this is working. Usually I see a few questions ahead of time, but nothing sitting there. So this is your opportunity to ask questions about the videos I've released this past week, about ADHD in general, or more broadly, mental health questions. And I will try to answer them with as much factual information as I can. Um, the information here is presented for the purposes of information. So I am not treating any of you. I don't have a doctor-patient recommendation. So take anything I say here with a grain of salt and take it to the people who are working with you. So without further ado, I will launch into the videos, a minute or two summary of the videos that were released. So the new video was about amlodipine, an antihypertensive, anti-high blood pressure agent in ADHD. And the sound re-recorded was on body-focused repetitive behaviors in ADHD. Good. So the amlodipine for ADHD was based on a study by Bruce Yankner and colleagues at Mass General Hospital, Boston. And it was actually a series of several experiments, starting with the premise that are trying to repurpose different medications that are already out there, already approved, already have a safety profile to see if they can be used for ADHD. And they had used a screening tool of a zebrafish model of ADHD, a specific genetically modified hyperactive strain of zebrafish, and had come up with, I think, 6 or 7 possible prospects. And then the first part of their study was to see, again, confirm that in zebrafish, these drugs did decrease hyperactivity. They added another test for impulsivity. And if you want to know how to measure impulsivity in fish, we can get into that. But they had a plausible mechanism. So not just hyperactivity, but impulsivity. And they also used a rat model, which has been used by many other groups besides theirs to study ADHD, possible implications and treatment effects. Anyway, so amlodipine was the only prospective medication they had that seemed to decrease impulsivity, decrease hyperactivity in both the rat and the zebrafish. Then they also did studies to prove that amlodipine got into the brain, because there were claims that it didn't actually pass through the blood-brain barrier and was only relevant in the peripheral circulation. So amlodipine, to back up, is an antihypertensive agent, and it's specifically a calcium channel blocker. So then they did studies looking at complex genetic studies called Mendelian randomization studies, which implicated the effects of certain subunits of the calcium channel blocker as possibly mediating the effects of amlodipine on ADHD symptoms. And finally, and the closest to any human direct research, is they looked in a large population study where there was polygenic testing to see who was relatively at increased risk for ADHD. So this was not meaning everyone had ADHD in this group. It's just a relative increased risk. And they found that of the people at the high propensity for ADHD, there was a less, and I'm not even remembering which ADHD traits, whether it was impulsivity or some 2 traits, seemed to be displayed much less than you would expect in the ADHD population among those getting amlodipine and not among those getting another antihypertensive agent. So it didn't seem to be just an effect of lowering blood pressure. So clearly the very next step, and these steps certainly support the reason or rationale for doing it, would be to make a random controlled study of treating people with ADHD, assigning some of them to amlodipine and some to to a placebo, and seeing if there was direct impact on ADHD symptoms. That, if it's been done, it has not yet been written up and reported, but So right now, again, we don't have direct, clear-cut evidence, but there's very suggestive background, baseline science evidence that it could be helpful. So the second video was on body-focused repetitive behaviors. So those are behaviors like nail biting, hair pulling. That's not why I am bald. Skin picking. And these are found more often among those with ADHD than they are in the general population. For decades, these behaviors were considered in the OCD spectrum, but some genetic and some just epidemiologic evidence indicates that they are more closely associated with impulsivity and, and difficulties resisting impulses connected with ADHD than they do seem to be connected with compulsive behaviors connected with OCD. And there's some fairly striking resemblance to animal grooming behaviors, social grooming behaviors, both in primates and rodents. And there's basic research in those species that implicates strongly glutamate in repetitive body-focused behaviors, which has led to at least a few recent experiments looking at glutaminergic agents such as memantine, which is a NMDA blocker, and N-acetylcysteine, which do seem to be helpful in reducing these behaviors and may be helpful in ADHD as well. So that's the videos, and I do see people are here and there's questions, so I will launch into the questions. Hi, Max. So Max says, if some ADHD symptoms may be linked to calcium channel activity, wouldn't mood stabilizers like lamotrigine show benefits for ADHD as well? So I don't have at the top of my head. So, I mean, the mood stabilizers is a very broad category. Many of them initially were anti-seizure medications and prevent a phenomenon called kindling of where a seizure is easily or hard to trigger to begin with, but the more you practice it, it's more easily triggered. All blockers are subtly different. So I see there's connectivity problems, so I don't know if anything got dropped. So even within the family of calcium channel blockers, there are differences in terms of which subunits of which calcium channel and how they're blocking and how they're interfering. So one of the studies within the Yankner larger paper was looking for effects of different calcium channel blockers on, I think it was one of the animal models. And I think of the 12 that they tested, only 2 others seemed to have some activity, and they were less consistent or less proportionate than the amlodipine. So it's, again, if this bears out, it may be something rather specific about how it's interacting with calcium channels rather than, again, a overall blood pressure effect or an overall any calcium channel effect. Dropneck says there seems to be a relationship with blood pressure and ADHD, a strong one, since if I'm not mistaken, guanfacine and clonidine also treat high blood pressure and ADHD. So again, guanfacine and clonidine are alpha-2 agents that affect the norepinephrine system and indirectly, I mean, work on blood pressure and help with ADHD slowly and indirectly, but significantly. I don't know. I mean, one of the basic questions is, do people with ADHD have overall high blood pressure or low blood pressure? I don't know what the data, if there is any, show about that. I don't know that the connection's that strong. And again, that the bigger point isn't, and I've written about this with dementia as well, that yes, blood pressure can have effects on the brain itself, but it seems that there are certain classes of drugs that are working. So, for example, beta blockers haven't been shown to have particular help with ADHD. They are good antihypertensive drugs, blood pressure lowering drugs. They also have effects on heart rate, heart rhythm, and they have effects on the sympathetic nervous system, which is presumably how they are helping with anxiety. But they're not, again, I don't think they've been shown to have much impact on ADHD. So there are, again, more specific. So part of it is that drugs that are having effects on one system can also be affecting other parts of the brain or body in specific ways that you might not have assumed from the beginning. Um, Hello, Nick Lewis. You're welcome for the videos. Thanks. I'm not asking no specific medical advice, but would really appreciate if I can give your opinion in regards to his situation. So I will try to provide general information without a specific recommendation. I have moderate severe OCD and ADHD traits, inattentive symptoms, executive dysfunction symptoms. I also have a peculiar neurologic, possibly neurodevelopmental reaction to visual stimuli and emotional arousal. I tense my arms, hold my breath, do repetitive movements. I'm on duloxetine 120, and it helps to address some of the core symptoms and some of the ADHD, attention, executive dysfunction, um, because of the serotonin transporter norepinephrine blocking possibility. Um, so I don't know. So jumping down below, I'm considering augmentation, but majority of medications are not available. I'm thinking about adding mirtazapine, which has some action on histamine and serotonin 2C and 2A activity to possibly improve sleep, counter duloxetine side effects. Um, yeah, I guess one thought would be whether guanfacine would have additional benefit in this scenario. I don't know if that's enough detail or I should further. Um, I'll jump through because I see different questions interspersed with yours. So I'll get back to Nick's, hopefully. So James Alexander, for increasing dietary omega-3s, why not eat canned or cooked fish a couple times days of the week instead of taking fish oil? So one unfortunate thing, I mean, one is fish varies considerably in its omega-3 fatty acid content. So it's the fatty fishes, the salmons, sardines that are particularly high. Other fish may or may not be as good a source. But the sad story is that, and different manufacturers use somewhat different protocols, but usually it's a distillation process getting from fish carcasses to omega-3s. I should say that there was a period, I don't know if it's still the case, that um, those cute little baby harp seals that are clubbed by those mean Canadians for their furs, seals which eat almost entirely fish also have high levels of omega-3s in their body. And so there were some companies actually using seals as a source of omega-3s, and they clearly couldn't say fish oil, or they had to modify how they advertise it. So they weren't saying cute little baby seal sources of omega-3s. Anyway, the distillation process actually pretty clearly for most manufacturers is substantially reducing your likely exposure to heavy metals. So particularly mercury, cadmium, which are known neurotoxics, may be less effective in reducing some of the fat-soluble plastics, the BPA and polyphenols, but pretty clearly less risk. So the sad story is that the dietary omega-3 fatty acid pill is probably a cleaner source of omega-3s in terms of less toxic metals than eating fresh caught fish, even in relatively clean waters, or canned or cooked fish. So, and again, information may change as we learn more about different plastic and other organic contaminants and how water supply or fish supply, our omega-3 supply. Thyself, John, came across my channel because he's about to start Severity and was watching some reviews, and he likes to learn. So great. Welcome, welcome to the live. And if you have questions, so Max provided the Severity link. So that's a combination of dextromethorphan and bupropion, Wellbutrin. Ostensibly, the bupropion is at below antidepressant therapeutic levels, and it's primarily there to block the breakdown of dextromethorphan, which is usually cleared from the body really quickly. And it is one of the few commercially available antidepressants that works quite rapidly within just a few days when it works. So thyself, John, talks about being stuck within the sympathetic nervous system. So I do have videos that might be useful on the connection between attention and anxiety, or between ADHD and anxiety. And my panic attack, even though specifically focused on panic attack, um, a lot of it's generalizable to less extreme forms of anxiety and engagement of the sympathetic nervous system. Oh, and I also have a video on getting getting unstuck from stuck states. So all of those may be helpful. So Nick Lewis is back with the OCD and some ADD aspects and some unusual neurologic aspects to his anxiety. So Stratera further enhanced noradrenergic tone and helped with ADHD symptoms in a more direct way. Yeah, I think the things you've suggested are logical. I mean, again, when we focus on specific neurotransmitters, an important thing to remember, and I have a talk on how we often simplify these things, is that all these systems are interacting and regulating each other. So even though we start with an agent that may be a specific noradrenergic reuptake inhibitor, the net effect is to mess with serotonin and norepinephrine and dopamine and glutamate levels in other parts of the brain. So I think it's useful to start with some thinking about neurochemistry, but I also think that clearly we don't have the brain all mapped out yet and know what all specifically for an individual what the implications of messing with one system are going to be. And oftentimes people, sort of the amlodipine story is an example, derive benefits in ways that we wouldn't expect from the agents, just based on what we think or what we focus on, how they're working. Max asks, would you say there's a limit to how severe ADHD symptoms alone can get? Is there a point of dysfunction that would lead you to determine there has to be a comorbidity like depression or anxiety? One, and this is particularly since, at least compared to many of the peers I interacted with in San Francisco, and I think also at a maybe national ADHD level, a lot of psychiatrists, a lot of doctors work with people who have insurance, and right away there, as opposed to working with people who have, I should say, private insurance, commercial insurance, Medicare or Medicaid plans. So Medicare in the US is for people either over the age of 65, it might have gone up a year or two. So the elderly, I'm almost there, and or the um, officially disabled. And Medicaid is a system for people with very restricted income who may or may not also have disabilities. Anyway, I've seen what I would say ADHD alone be completely impairing. So in terms of the severity, and this is Frank, who was the first patient I started working with, a nice guy, had held more than 100 jobs, and none of them more than 6 weeks, most of them no more than 2 weeks. And depression was not a factor, anxiety wasn't a factor, and it was robust ADHD, being so distracted he couldn't stay on task and would engage, would miss important information. But separate from the work history, one of my examples of how severely impairing ADHD alone can be, he had tried a bunch of other medications when they hadn't identified ADHD as a factor. So when I started working with him after it was clear that ADHD was what he was dealing with, we tried Concerta, and it helped him function far better than any of the antidepressants, anti-anxiety agents he had. He saw the effects. It wasn't just me telling him there were effects. And I was seeing Frank for an hour every week. This is in the days before cell phones and easy reminders and coaching systems. I'll get to why I'm bringing that up. So every week I would, among other things, check in with, how are you doing with the Concerta? And he'd say, oh, I know I missed it a few times this week, but I'm still taking it. I know I missed. And he would not fill the next prescription, not once a month, not every, so it was a month 30 pill prescription. It would not be 2 months, it was 13 months before he filled the next prescription. And actually, over about a 5 or 6 year period, it kept being 13 months, which meant that he was on average, and the math works out this way, taking the medication only about once every 2 weeks, which meant half the time when I'd seen him week to week, he had not taken it a single time, even though he had seen it work. He was trying to report accurately what was going on, his own ability to track each day whether he had taken it. And we used pill bottles. We used, again, maybe in the more modern era, sending him a text message every day or sending up a reminder on a phone might have helped him to be more compliant. But again, the point here was that his ADHD was so severe, it really, really affected his ability to follow any treatment that helped his ADHD. So I think ADHD alone can be really severe and really incapacitating. I do think, and the statistics would certainly bear this out, the more severe it is, the more likely you are to also have concurrent depression, anxiety, substance abuse, other problems. Um, how much of that is a common genetic effect? How much of it is lifestyle, social world, other feedback loops? How much of it is direct ADHD leading to depression or anxiety? And how much is depression also and anxiety impairing executive functions and making ADHD worse? I think all of those are likely going on. Hi, Dennis. Dennis asks, why does living in urban areas as opposed to rural areas increase the risk of psychosis? So I do have a talk, I think, about nature, the benefits of nature. I know I've written about it on Medium in maybe more detail. So we have epidemiologic data and we have lots of theories, and I'm not aware of any that have nailed it down, although there's an interesting article in this month's journal, American Journal of Psychiatry, that was looking more specifically at racial differences, but not moving beyond racial differences, looking at the impact of social environment and holding race constant. There are measurable effects of the environment, poverty, stress. I'd say the simplest answer is that the urban environment is presumably and by many measures, a more stressful environment, and brains that are already vulnerable are more likely to be pushed into a psychotic state. Um, there's also been, and I may even wind up doing a talk on this, revisions to the basic mechanisms of what's contributing, or what, how do people, or why do people develop delusional thoughts and or hallucinations. And the predominant theory for 2 decades was an aberrant salience, that for, maybe because of underlying problems with dopamine weighing, dopamine strength of dopamine systems in certain circuits in the brain, that this was contributing to giving undue attention, importance to certain facts rather than more realistically, or weighing different information from different sources. And that once your brain gets hijacked by a delusion, that process continues. So, so I don't know if that helps. So Dennis's follow-up question is that he's referencing some of the work of Dr. Andreas Meyer-Lindenberg, and I'm not sure what Dr. Meyer-Lindenberg's specific conclusions or observations were. So if I can try to comment more with more input, but I'm sort of, that's at the end of my information at the moment. So one of the things, and this is work of Amy Arnsten and colleagues, multiple colleagues at Yale and elsewhere, on guanfacine. So guanfacine seems to not only slowly and indirectly lead to increased synaptic connections in the prefrontal cortex and the forebrain, so helping sort of top down regulate a variety of different systems, including potentially regulating sensory motor systems, but also seems to weaken some of the strengths within the amygdala, which over connections there, over strength there, tend to lead, this is an oversimplification, to emotions overriding conscious thought processes. So potentially, yes, the effects of guanfacine may help with strengthening wiring in areas we want to strengthen it, and weakening it in areas we don't want to strengthen it.